Emma Tippett, infectious disease consultant and research fellow still from this morning, and also have one conflict of interest. So I described the way our clinic works this morning, but as I mentioned, the reason I started the clinic is because I became aware of low-dose naltrexone and the fact that we finally had something that we could offer people with long COVID. So I, much like we've heard before, I've been using it for several years now, and felt that it was probably time to put some data behind my clinical experience. So this presentation is aimed at people who are prescribers but who do not yet prescribe naltrexone, so that they can hopefully get a better understanding of how it works, and also for prescribers to, I guess, share our experience and see if there's any differences in what we do. Low-dose naltrexone itself is a competitive opioid receptor antagonist, is a relatively short half-life and an active metabolite. The label use is for opioid overdose, substance abuse and weight loss at doses closer to 50 to 100 milligrams a day. And it is safe up to 800 milligrams in category C pregnancy, and the only contraindication is in severe liver disease. The mechanism of how it works in ME/CSF and long COVID is not fully established. As we heard this morning, there is a hypothesis that after the antagonism of the opioid receptor, there's upregulation of endorphins. More recently, in vitro work has showed microglial and macrophage TLR4 receptor pathway inhibition, reducing inflammation. And there's a group in Queensland in Australia that's quite strongly focused on TRM3 ion channel and low-dose naltrexone restoring that function in both the brain and the immune system. But I think there's still more work to do to fully understand how low-dose naltrexone works. In terms of long COVID, there hasn't been a large number of studies to date, which is where the evidence is lacking. The first box there are generally retrospective or observational studies with very small sample sizes. The meta-analyses to the right there, two of my colleagues simultaneously and independently undertook a meta-analysis of low-dose naltrexone and came to the same conclusion that out of the 2 or 3 studies that reached criteria for inclusion, that there's an improvement in fatigue and a few other symptoms. Fortunately, there are clinical trials underway, including Recover TLC, so we will have some more firm answers, but the numbers are not huge. I'm not sure if this is enough for naltrexone to be included on the FDA in Australia. I don't think that clinical trials less than thousands of people will make a difference in terms of subsidies. I'll also draw attention to the dosages used in these clinical trials, because I'll talk about that in a moment. So, as I said, I feel it's time to actually put some data behind a lot of our work, and so as part of a much larger study looking at the therapies that people at our clinic have used and actually in Australia have used, one of the optional questionnaires is on low-dose naltrexone, and it's basically patient-reported outcomes based on the global impression of change type questions. So far, I've only sent it to 300 patients, but as I just have a few more things to sort out, then I'll increase the number of returnees. And we're receiving a 30% return rate, which isn't too bad for a voluntary questionnaire. The aim of the questionnaire is to identify effective therapies, particularly focusing on hard to access or expensive ones like plasmapheresis, which is now available in Australia, to define and determine the impact and the side effects of particular medications, and also to gather practice points about some unanswered questions. But focusing specifically on low-dose naltrexone, what did we find? Out of the 100 or so respondees, the vast majority of people returned at least a slight benefit, if not a decided improvement. About 20% reported no change at all. In terms of the actual symptoms that low-dose naltrexone has the most impact on, fatigue and brain fog were by far the biggest impact, which is what we'd expect. But pain, there are a few people there with a vast improvement in pain, and I would like to talk about the impact of low-dose naltrexone on fibromyalgia type pain a little bit more. And overall, people were satisfied and willing to recommend low-dose naltrexone. In terms of the side effects, you would have heard the keys to start low, go slow. I was actually quite surprised with this, that The majority of people reported that they either had no or mild side effects. So this means that you probably can go much faster to a higher dose, which means people are getting into receiving a therapeutic effect a lot faster. However, there are a group who reported moderate to significant side effects, and for this group, low-dose naltrexone is truly awful. It can be really horrible starting in some people, and I'll talk about that a bit more as well. The most expected side effects of low-dose naltrexone is disturbed sleep, in particular vivid dreams, headache and gastrointestinal side effects. So that's what you can tell your patients in terms of their symptoms. Now, this is the point that I wanted to make for people who are prescribers. All the studies so far have stopped at 4.5 milligrams, if not 6 milligrams. Through patient feedback, where more than a couple of my patients accidentally took 2 doses of low-dose naltrexone, we found that people have additional benefits up to 10, 12.5 milligrams. The reason there's a lot of people at 12.5 milligrams is because that's 1/4 of a 50 milligram tablet, so that improves access. So more than 50% of our patients do better at above 5 milligrams of low-dose naltrexone. There are a significant number of people stuck at less than 2.5 milligrams or even less than 1 milligram of low-dose naltrexone, and recently pharmacogenetic studies have become more popular in Australia, and we've had a handful of people who have had these done that are in this group that have shown polymorphisms that affect low-dose naltrexone metabolism, and so that's probably what's going on for that group. There will be a genetic polymorphism that accounts for the people who do not tolerate low-dose naltrexone well. And alternatively, I've also seen slow metabolizers, and so I do have a patient who knows that they're a slow metabolizer and they're moving up to 20 milligrams. In terms of practice points, what does this mean for the patient? So it's not a silver bullet, it's not a cure, unfortunately, but in my opinion, it is the best thing that we've got so far. It is the most universally effective medication for fatigue. That what it means for an individual might mean that they still can't do more, but they feel less terrible for the whole day. Or it might mean that they can do a few more hours work a day. They still need to pace, they still need to make all the lifestyle modifications, but it can have a major impact there. In terms of fibromyalgia pain, it can be absolutely incredible, especially at the higher doses. And so to remove somebody's chronic pain is a big thing, even if you haven't improved their function. So my advice is that if they have any fibromyalgia pain residual at 4.5 milligrams, just keep going up. I do start at 5 milligrams for most people, so I prescribe it as a liquid to start off with, tell them to take 5 milligrams on the first day, every third day for a couple of weeks, and if they do okay with that, they can bring it together till they're taking 5 milligrams a day, and then when the bottle's finished, I'll change them over to a capsule for cost reasons. If they don't tolerate, because it's a liquid, they can just drop down to 1 milligram, half milligram, whatever works for them, even down to 0.1 milligram if they can get a syringe that will measure that much. The onset, to advise a patient, the onset can take a few days. Some people will take a few days, but some people will take a few weeks. And I think that there are a lot of people who will tell you after 2 months that they are, they don't think that it's working, but then like the second quote here, they stop it and they have a severe relapse, so they probably just don't realise that it's actually doing something. So I never let my patients stop or give up. I make them try at least 3 times before I let them say that low-dose naltrexone doesn't work. We've never had an allergy, and we've never had liver or renal impairment in terms of pathology for patients, and Wikipedia says that there was an intentional overdose of 1,500 milligrams, which was uneventful. So that goes to show how safe low-dose naltrexone is. You really can't hurt somebody other than with the neuropsychiatric effects, and the only way to know is just to try it. The other point that I'd really like to make is that it can be used in children. As we know, we're about to have that data, but what we find is that there's a lot of hesitancy in prescribing in children, but low-dose naltrexone might mean the difference between school attendance and not school attendance. So low-dose naltrexone plus POTS management in a child can make a huge difference. So please don't withhold medications just because they're a child. In terms of pregnancy, we have had clinicians some of my clinicians are fetal maternal medicine doctors, and they will use low-dose naltrexone, counselling the patient that it is category C if the patient feels that they need it. Right, I'm out of time. I did want to talk about some of the early feedback from nicotine patches, which is another medication that we use for fatigue management, which I think was also mentioned in one of the earlier studies, but we'll skip over that because I've run out of time. But final conclusions are that whilst the evidence for low-dose naltrexone is still lacking, there is extensive clinical experience and patient feedback, and so don't hesitate to use it. But there are significant barriers still to accessing low-dose naltrexone. The first one is being comfortable prescribing it, which hopefully I've helped with here. The other is the cost, because it is off-label, and access to the compounded medication as well. Thank you.
Thank you so much.